It's 22 minutes past 8. Welcome back to Sunrise Daily. We're coming to you live from O'Hara in Delta State. We're joined now by Governor of Delta State, Dr. Emmanuel Uduaghan. Thank you for coming on this morning.
Thank you very much. Welcome to welcome to Delta State. I live on Thursday.
Oh, thank you too. We've gone round the health facilities, some of them, not all, even though we've got questions about some others coming through, which we hope to bring up. But when you came in, we understand you came up with some programs, for instance, the maternal mortality rate. But give us an overview of what you intended to achieve and how far you've gone.
Well, when I came in, like you're all aware, I had this 3-point agenda of infrastructure development, human capital development, and peace and security. Now, under the human capital development, we had 3 broad areas: the health area, education, and of course empowerment. So for the health sector, we had, being the former commissioner for health, I had a fair idea of the status of our health. When I left, I became the SSG. While still the SSG, I still kept my eyes on the health sector. And of course, now that I became a governor, so I had a fair idea of what we intended to achieve. Now, there are 3 broad areas in dealing with health issues: the primary health care, the secondary health care, and the tertiary health care. The primary health care basically is a collaboration between the local government councils and the state, and sometimes the federal government. But most secondary health care is under the state, purview of the state. And of course, tertiary between the state and the federal. So our emphasis was, how do we improve on the primary health care? Of course, deal majorly with secondary health care, and also lay some emphasis on the tertiary health care. Now, in dealing with the primary health care, we were more particular about the killer diseases, and of course the issue of maternal and under 5 children. The 2 major issues in healthcare, especially at that level, is ignorance and poverty. Poverty in the sense that because a lot of our people first do not take health as priority, so nobody keeps money in case you have a health challenge. Such that when the health challenge comes up, you see people cutting around for money, and when they do not have money, they easily resort to quack. Of course, ignorance, because we are not educated, a lot of myths around health. So in dealing with that, the primary healthcare sector, using these 2 factors of ignorance and disease, we tried as much as possible to see how we can assist the people at that level in dealing with their health issues by making sure that the cost of health at that level is not too much at that level of persons. And that is why we had our free maternal healthcare services. That's why we had our free under 5 clinics, under 5 healthcare service. Of course, a lot of immunization issues and a lot of our rural healthcare programs that were free. And that was also combined with education to deal with the issue of ignorance. Now, on the secondary and tertiary, which are areas that deal with more sophisticated illnesses, illnesses that people go outside. Some go outside to go and get treatment for. We thought we could improve on our services at the secondary healthcare level and on the tertiary healthcare level. So we in dealing with that, we needed to deal with infrastructure, equipment, and of course the personnel to run those facilities. So far, we've tried to deal with the infrastructure in some of the hospitals. Like we have heard, we have about 65 hospitals, 6 specialists and the general ones. Now, in the number of years that I've been a governor, we have tried to improve on the equipment in those hospitals. We are still dealing with the infrastructure. This year, for instance, the major specialist hospitals will deal with the infrastructure, like Ughelli, Sapele, part of Warri, Kwale, and some of our hospitals that still require renovation of the infrastructure. In fact, Bumadi and Patani will deal with that within this year's budget.
When you talk about hospitals and renovation, someone has asked before now about the hospital in Agbaro. He says, well, it looks like it's not been in use.
No, that Agbaro hospital really, I would say, was a private enterprise by, I don't know whether he's talking of the State General Hospital or the one.
I think it's the General Hospital.
No, so if it's not being used, then I think it's in Koyebori Children's Hospital, if it's that one. And that hospital really was built by the wife of my predecessor as a pet project. It was a government project.
Okay, I think I just confirmed this General Hospital. He said General Hospital in Agbaro was commissioned with pomp and pageantry, but is covered now by weed because it's not been in use.
No, that's not true. General Hospital in Agbaro has been in existence even before, during the military administration, and it's always been in use. The hospital in Agbaro that is not being in use is the Koyebori Children Medical Center. That was the pet project of Mrs. Koyebori. We did not take off because the concept, the way the hospital was planned and the location and all that affected its taking off. So that is the Koyebori hospital. It's not a government hospital, it's a private. Although what we are trying to do as a state government now is to take over the facility. But I will not advise anybody to run it as a hospital because I have my own. I don't think it's well located, and the concept was not properly articulated.
But what is being done to ensure that you don't have people moving straight to the tertiary level rather than go for primary healthcare, because you have that in some cases?
Yes, for what the challenge we have really is again ignorance. Now, the tertiary healthcare services that we have, the major one is the teaching hospital where we are in now today. Of course, we have the Sapele, we have Warri, and 4 other places, Agbo and all that. Now, in those specialists or tertiary healthcare hospitals, you cannot you cannot prevent people generally going to them. What you do in such places is you create a unit called the family healthcare unit as part of that tertiary hospital, where people go just for first attenders in the hospital. They go there, and from there, now the specialty in family healthcare practice. So the doctors they sit there can now sort them out. If they require specialist care, can refer them to the specialist. But if you say people should not go to the tertiary hospital as a first point of contact, it's fairly difficult. So you just create the family healthcare unit in the tertiary hospital where they are seen first, and somebody sorts them out.
No, we're actually asking the CMD of this hospital how he's been able to manage with people coming with all the facilities here, knowing full well the lifestyle of the people. It is, not an urban area you talk of, but you have the serene environment. So if they come in, for instance, the dialysis machines we saw yesterday, 8 of them, and some of these people have any of such challenge, how do they, because he talked about subsidies from the government, he didn't give us a breakdown of how this works, but maybe you should tell us how it operates.
Okay, talking about the community and the hospital, initially it was a big challenge, but what we've also done is this community had another hospital before this teaching hospital came up. Yeah, it had another hospital, and that hospital is still operational, so they still go there. But it's difficult to say, okay, they should not come here when they have this beautiful hospital and all that. And I think he also created a family practice. But if it requires services that cost money, and they say, oh, because we are from this community, we should be entitled to. Yes, it's under our community relations program. Of course, the state government, if we get such cases, the state government will pay for it, as a community relations activity for the hospital. But generally, we've not had too many of such cases. But the government will obviously deal with it.
We also did ask about sustaining this facility and the service, in fact, across the state, because as you all know, you may have someone who maybe his central focus may not be health. What kind of program are you putting in place to ensure that the whole system just runs itself?
Now, health, majorly for now in Nigeria, is a social service. I'll just tell you a brief history about this hospital. The concept of this hospital actually came up when I was Commissioner for Health. Two elders in this community, they had come to my office and said, look, put a specialist hospital in Ugara. I love that. And that got me thinking. And based on my knowledge of hospitals outside this country, where you have hospitals dedicated to specific illnesses, they are centers of excellence for such illnesses. So they are primarily hospitals that deal with such illnesses or specialized cases. And on the secondary level, they now do teaching. So you see people going there because of the specialty. People go there to learn certain specialties. So they are not primarily teaching hospitals, but they do teaching. So that was the concept I had in mind, when I went to discuss with my boss about this hospital, which said, okay, let's go ahead, and we started developing it. Unfortunately, when the project started, a lot of issues came in, and they said, okay, let it be primarily a teaching hospital. But we are where we are today. In moving forward, I still believe, and that's what we are working towards, that yes, a teaching hospital, but it should be a hospital that is known for specific illnesses, specific areas, specific specialties, and I think we have chosen 5 or 6 areas. Now, why I'm emphasizing that is that for the hospital to sustain itself, it has to move away from less social service and offer services that people pay for. For the social treatment, the other 5 or 6 specialist hospitals in the states and the other 60 general hospitals can handle those social areas where people either pay nothing or pay very little. But before I leave, this hospital is going to gradually get to a situation where if you are coming here for that kind of specialized service, you pay for it.
Will it be world standard?
Yes, it's going to be world standard, and that is why I said you have to pay for it. Now, the other thing really, why I've laid emphasis on bringing this diaspora and the equipment and all that, is that as part of our Delta Beyond Oil, we were looking at areas of tourism. And one area of tourism is medical tourism. People today are running to India and all that. And for a patient who is going to India, usually they go with 1 or 2 persons. They will have to stay in a hotel, they have to eat. Sometimes by the time they are coming back, they are buying 1 or 2 things. So it's not just even the hospital they go to that benefit from their presence there. And that's the kind of system we are trying to create here. Now, people will come here, pay for the services. People will build hostels, build hotels around the place, collect money from the people. But that kind of medical tourism.